Usually when you talk about taking a prescription, there's like this underlying expectation of precision.
Oh, absolutely, yeah. You want it to be predictable.
Right. It's like basic engineering. You have a headache, you take a pill stops the headache. It's a very clean binary transaction.
That's a comforting narrative, for sure.
Yeah.
We want our medicine operating with, mathematical consistency day in and day out.
But when you step into the world of psychiatric medication, specifically for women, that neat little equation is just completely thrown out the window. It's not a fixed formula at all. It's a biological tug of war.
Yeah, it is the absolute definition of a moving target. I mean, what works flawlessly on a Tuesday might be practically useless or even toxic by the following Thursday.
Just because the underlying environment of the body has shifted.
Exactly.
Well, today we are going to explore exactly why that happens. Welcome to today's deep dive. We're glad you're here with us. We've been looking through a massive stack of medical journals, psychiatric guides, and physiological studies just for you.
Yeah, there is a lot of dense material here.
There really is. And our mission today is to answer a highly specific but incredibly vital question. How does a drop in estrogen completely alter lithium levels and fluid retention in women who are treating bipolar disorder?
It's such a hidden battle inside the body. And the crazy part is, standard medical guidelines often completely ignore it.
So where do we even begin with this?
Well, to really grasp this, we actually have to start by looking away from the brain.
Wait, really? Away from the brain?
Yeah. Now, you would expect a psychiatric discussion to begin with neurotransmitters, but we actually need to look at the kidneys.
Okay. The kidneys.
Right. They're the body's master fluid regulators. And for women, the hormone estrogen essentially acts as like the master control dial for water and salt balance within those kidneys.
Let's break down exactly how that dial works then. I mean, we all know the kidneys filter blood and make urine, but the sources show estrogen is heavily involved in the microscopic details of that filtration.
Oh, heavily involved.
The clinical data says that estrogen lowers the operating point for something called the, let me get this right, the osmoregulation of arginine vasopressin, which is a massive mouthful of medical jargon.
It really is.
What is actually happening there?
So arginine vasopressin, or AVP, is an antidiuretic hormone. Its entire job is to tell your kidneys to conserve water.
Okay, so it holds on to fluid.
Right. And osmoregulation just refers to how your body senses the concentration of your blood. So when estrogen lowers that operating point, it's basically making your brain hypersensitive to hydration levels.
Meaning you feel it sooner.
Exactly. Estrogen tells your brain to get thirsty sooner, and it commands your body to release AVP and hold onto water much earlier than it normally would. And, well, this leads directly to a higher volume of plasma in your blood.
Wow. And it doesn't stop with just water either. The sources point out that estrogen also stimulates the renin-aldosterone system.
Yeah, that's the other half of the equation. Aldosterone is a hormone that acts like a microscopic salt magnet in the kidneys.
The salt magnet. I like that.
All right. Right, so when estrogen turns up the aldosterone dial, it signals the kidneys to pull sodium out of the waste fluid and just shove it back into the bloodstream.
And a basic rule of biology is where sodium goes, water follows.
Bingo. So high estrogen triggers a direct sodium retaining effect. It's essentially hoarding fluid inside the circulatory system.
It kind of reminds me of a strict bouncer at a nightclub. Like estrogen is the bouncer, carefully managing exactly how much water and sodium is allowed to stay inside the bloodstream's VIP section.
That's a great way to put it, yeah.
But wait, I have to push back on this because it seems like a huge contradiction.
Oh, how so?
Well, if high estrogen fundamentally causes the body to retain sodium and water, why do the sources say women experience the most bloating and water retention during menstruation? That is exactly when their estrogen levels are supposedly dropping. It seems completely backward.
Ah, yeah. It is a brilliant contradiction. It honestly confuses a lot of people.
Right.
The thing is, the bloating isn't caused by a static high level of estrogen. It's actually caused by the withdrawal.
The withdrawal.
Yeah. During the menstrual cycle, it's the fluctuating hormones, the shifting ratio between estrogen and progesterone, that throws the whole plumbing system into chaos.
Oh, I see. So it's the sudden shift that stresses the system, not the hormone itself just sitting there.
Exactly. When estrogen suddenly drops, the body scrambles to adjust all those microscopic dials we just talked about. This sudden withdrawal stresses both the gastrointestinal and the renal systems.
So the kidneys kind of lose their grip.
That's exactly it. They temporarily lose their tight, regulated grip on fluid distribution. So instead of staying neatly in the bloodstream, that fluid shifts outwards into the surrounding tissues.
And that's what causes the physical sensation of bloating and abdominal swelling.
You got it.
Okay, so that fluid shifting doesn't just cause physical discomfort, though. And this is where we transition from general fluid dynamics to the psychiatric side of things.
Right, because this directly impacts whatever medication happens to be dissolved in that blood.
Which brings us to lithium. Lithium is, a vital frontline mood stabilizer used to treat bipolar disorder.
A very common and very effective one.
But the research shows that women generally have lower lithium clearance than men. And not only that, they present far more variations in their clearance rates.
Yes, and those variations are directly tied to the hormonal calendar. The psychiatric literature highlights a really specific, highly documented phenomenon. It's called a recurrent premenstrual decline in lithium concentration.
So literally, in the days right before menstruation, the amount of lithium circulating in a woman's blood just drops.
It drops significantly, and this has direct clinical correlates. It can negatively affect the evolution of bipolar disorder, leading to relapses right before menstruation.
Think about the physical mechanics of this. It's like brewing a cup of tea in a constantly resizing mug.
Oh, I love that analogy.
Right. If your body's fluid volume is constantly shifting and redistributing because of the menstrual cycle, the strength or the concentration of that lithium tea is inevitably going to fluctuate.
It's a perfect way to visualize it. If your blood volume expands or contracts, those milligrams of lithium become either too concentrated or completely diluted.
But wait, is the body just diluting the lithium because of that water retention we just talked about? Or are the kidneys actually flushing the drug out of the body faster?
It's actually primarily active flushing.
Really?
Yeah, and this links right back to estrogen's grip on the kidneys. See, estrogen significantly increases renal blood flow and something called the glomerular filtration rate, or GFR.
Okay, GFR, what is that exactly?
Think of GFR as the literal speed limit of the kidney's filter.
Ah, okay.
When estrogen and progesterone fluctuate and drop right before menstruation, they fundamentally alter that filtration speed.
So the premenstrual drop in hormones changes the kidney's dynamics.
So drastically that it actively clears the lithium out of the blood and just dumps it into the urine.
Wow. So it directly causes a massive dip in the medication's concentration.
Yep.
Imagine taking this medication and starting to spiral into a severe depressive or manic episode right before your period. You would probably think, your bipolar disorder is getting worse, or your willpower is failing.
Or that your brain chemistry is just broken.
Exactly. But what's actually happening is your kidneys are quite literally washing your psychiatric stability down the drain.
It is a profound realization. The psychiatric stability of the brain is entirely at the mercy of the kidney's hormonal plumbing system.
That's terrifying, honestly.
It is. And a monthly premenstrual dip can easily lead to a severe psychiatric relapse if the dosage isn't adjusted to account for that washout.
Okay, so if a monthly hormonal drop causes that much chaos, what happens when the drop is permanent? Let's move from the monthly cycle to menopause.
This is where things get really intense.
Right, because the clinical data outlines how the permanent drop of estrogen during menopause drastically alters both bipolar symptoms and how lithium functions in the body.
The menopause transition is arguably the most critical vulnerability window in a woman's life regarding psychiatric care.
Because of the steep decline in estrogen.
Exactly. And this matters immensely because of the estrogen protection hypothesis.
Which basically says estrogen acts like a neurological shield, right?
Yes, it is inherently neuroprotective. It shields the brain against psychotic symptoms and mood instability.
So when that shield is permanently lowered during menopause, women experience a massively increased vulnerability to psychosis.
And underlying bipolar symptoms are often severely exacerbated.
So that's the brain losing its natural biological shield. But then, simultaneously, researchers conducting clinical studies on pre- and postmenopausal women found something else.
The drop in lithium.
Yes. They revealed that serum lithium levels decrease considerably in the postmenopausal period, like a massive statistical drop.
It is a staggering double vulnerability.
Yeah.
The natural shield drops, and the medical shield plummets right alongside it.
It's a total double whammy for anyone going through this. And that drop in lithium isn't just a random accident either, is it?
No, not at all. It's accompanied by an entirely altered mineral profile on the body.
Right. The sources mention lower calcium and vitamin D, but higher zinc and phosphorus. Why does losing estrogen completely scramble the body's minerals like that?
Because estrogen is essentially the invisible conductor of the body's mineral absorption.
Okay.
For example, estrogen normally helps regulate calcium absorption in the gut and maintains bone density. When estrogen permanently leaves the system, blood calcium levels drop.
And the body just scrambles to fix it.
Right, it tries to compensate for this new reality by changing how it processes and absorbs other minerals like zinc and phosphorus. The entire metabolic baseline of the body is rewritten.
But wait, I have another question about this because the clinical literature notes a really specific, fascinating chemical relationship here.
The antagonism.
Yeah, it says lithium actually antagonizes the effects of estrogen. It fights against it.
It does.
Well, if lithium is fighting estrogen, wouldn't a massive drop in estrogen during menopause make the lithium stronger? Like if the opponent leaves the ring, the lithium should win the fight and be more effective rather than less, right?
You would naturally assume so. It seems logical. But biochemistry rarely works like a simple seesaw.
Clearly. So what's actually happening?
Because they antagonize each other, they are actually deeply entangled in a biochemical dance. Lithium relies on that baseline mineral environment, the one carefully curated by estrogen, to distribute itself effectively into the cells.
Oh, wow. So when the total depletion of estrogen rewires that mineral metabolism?
It changes how the kidneys handle minerals across the board. Without estrogen setting the stage, the standard dose of lithium is effectively lost in a completely foreign physiological landscape.
Which really highlights a glaring systemic failure in modern medicine. We rely so heavily on sex-neutral psychiatric guidelines.
That's a massive oversight.
A doctor will very often prescribe the exact same dose of lithium to a 25-year-old premenopausal woman and a 55-year-old postmenopausal woman and just expect the exact same result.
They are giving the identical medication dose to two entirely different biological environments. We are desperately trying to treat the brain while completely ignoring the systemic hormonal environment that dictates how those drugs even reach the brain.
Speaking of how drugs reach the brain, let's look at the physical toll this medication takes on the body along the way. Because while lithium is an absolute lifesaver for bipolar disorder, it is incredibly harsh on the very organs trying to process it.
The kidneys take a real beating.
Yeah, the sources say lithium can induce a severe condition called nephrogenic diabetes insipidus, or NDI.
Yeah, NDI is a major clinical hurdle. Essentially, chronic lithium exposure damages the kidney's physical ability to concentrate urine.
Which leads to severe polyuria, which is excessive, uncontrollable urination.
Right, and natriuresis, which is extreme sodium loss.
So the kidneys just completely lose their grip and start dumping water and salt constantly.
Exactly.
And earlier we established that estrogen normally increases sodium reabsorption. It holds on to salt.
It does.
So researchers looking at this severe sodium loss caused by lithium toxicity decided to test a surprising hormone-based intervention. They tested a drug called tamoxifen.
Yes, tamoxifen. It's a selective estrogen receptor modulator, or a SERM.
And it's very famous for being an anti-estrogen drug, right?
Yeah.
Widely used in breast cancer treatment to aggressively block estrogen.
That's what it's known for, yes.
And surprisingly, the data shows tamoxifen successfully decreased the lithium-induced natriuresis and polyuria by saving something called AQP2 water channels in the kidneys.
Yeah, AQP2 are essentially microscopic floodgates inside the kidney tubules.
Okay.
Lithium toxicity acts like a wrecking ball, destroying those floodgates so the water just flows right out of the body. Tamoxifen steps in and actually prevents the downregulation, the destruction of those AQP2 channels.
It's like fighting a fire with dry ice, using an anti-estrogen drug to fix a plumbing leak caused by a psychiatric medication.
It's a very clever intervention.
But I need you to clarify this for me. If estrogen normally retains sodium, why would you use a heavy-duty anti-estrogen drug like tamoxifen to stop the massive salt and water loss caused by lithium? Shouldn't an anti-estrogen make the kidneys lose even more water?
That is the exact paradox researchers had to unravel. And it all comes down to how SERMs work. The key word is selective.
Selective?
Think of tamoxifen as a pharmaceutical double agent. It wears a different uniform depending on which organ it travels to.
Oh, really?
Yeah. In breast tissue, it puts on its anti-estrogen uniform and forcefully blocks estrogen receptors to starve cancer cells. But when it travels to the cardiovascular system or the skeletal system or the kidneys,
It takes off the uniform.
exactly, it takes off that uniform and actually acts estrogenic.
Wait, so it mimics estrogen in the kidneys?
You got it. By modulating those specific receptors in the renal system, tamoxifen bypasses the lithium-induced damage.
Oh, wow.
It mimics the protective, water-retaining effects of estrogen, specifically at the site of those AQP2 floodgates, effectively rescuing the kidney's ability to hold on to water and salt.
That is incredibly sophisticated. It proves just how structural these hormone receptors are to the physical integrity of the kidneys, especially when they are under the intense stress of heavy psychiatric medications.
It proves you cannot separate renal health from hormonal health or psychiatric care from either of them. They are a single, continuous system.
So, how do we translate these complex physiological mechanics into actual practical care for the women navigating this today?
That's the million-dollar question,
Because, as we pointed out, standard treatment guidelines remain largely sex neutral. They prescribe the exact same size shoe for every patient, regardless of their actual foot size.
which is incredibly frustrating. But we are slowly starting to see a shift in clinical practice, particularly for women dealing with midlife hormone changes.
Right. When women hit perimenopause and menopause, as that neurological estrogen shield drops, they frequently experience severe focus issues, intense brain fog, and depressive episodes.
And to treat this, there is a growing use of a different formulation of lithium, supplemental lithium orotate.
Now, the standard heavy-duty prescription for bipolar disorder is lithium carbonate, right?
Yes. But lithium orotate is gaining serious traction because it provides cognitive support at vastly lower doses.
And because the dose of elemental lithium is so much lower, it comes with far fewer adverse events.
Exactly. You don't need the intense, constant blood monitoring required by high-dose lithium carbonate just to ensure your thyroid isn't failing or your kidney water channels aren't being destroyed.
Which sounds amazing. If lithium orotate is vastly safer for the kidneys and doesn't require constant blood draws, why isn't it just the default prescription for every single woman treating bipolar disorder? Why even use the carbonate form at all?
It's a vital question, but we have to look at the severity of the psychiatric load.
Okay, what do you mean?
Well, the clinical data specifies lithium orotate primarily for brain fog, focus issues, and milder depressive episodes related to hormonal shifts.
Ah, so it's not as strong.
Right. Full-blown bipolar disorder, particularly when it involves severe acute manic episodes and psychosis, requires immense clinical intervention. It still relies on the heavy-duty, proven clinical efficacy of lithium carbonate to quickly bring severe mania under control.
So it's a matter of matching the tool to the severity of the fire.
Exactly.
You don't need a massive high-pressure fire hose to keep a garden green during a dry spell, but if the house is actually on fire, you absolutely need that fire hose.
Precisely. A postmenopausal woman dealing with the loss of focus and depressive dips caused by an estrogen drop does not need the same aggressive, kidney-taxing carbonate dose as a 20-year-old experiencing acute, dangerous mania.
So hormone-informed care doesn't mean throwing out lithium carbonate entirely.
Not at all. It means recognizing these biological differences and adapting the specific type and dose of the drug to the woman's actual hormonal timeline.
We've covered incredible ground today. We started by looking closely at the kidneys, uncovering how estrogen acts as the master dial for fluid retention and sodium balance.
Right, the AVP and aldosterone dials.
Yes. And we mapped out how the monthly drop in that hormone physically alters how fast the kidneys filter blood, leading to that dangerous premenstrual dip in lithium levels that can so easily trigger a psychiatric relapse.
We also unpack the profound double vulnerability of menopause.
Right, where the loss of estrogen strips away the brain's natural protection against psychosis while simultaneously scrambling the body's mineral metabolism.
Causing lithium levels to plummet in a completely foreign physiological landscape.
And we looked at the sheer complexity of selective drugs like tamoxifen acting as a double agent to save the kidney's water channels from lithium toxicity. And finally, we discussed the absolute necessity of moving away from one-size-fits-all sex-neutral guidelines, pointing toward targeted, hormone-informed therapies like lithium orotate.
The overriding truth here is that you simply cannot separate the brain from the body. Psychiatric care must inherently be systemic care.
If there's one thing for you to take away from this, it's that the landscape of medication isn't a static, clean equation. It is a living, breathing ecosystem. And I want to leave you with a final thought to ponder.
Oh, this is a good one.
We now know that lithium fundamentally antagonizes estrogen, and that estrogen levels directly dictate how long lithium actually stays in the bloodstream.
Right.
If that is an established biological fact, could tracking a woman's natural hormonal rhythm, perhaps using a daily biosensor for estrogen and progesterone, rather than relying solely on generic monthly blood tests, ultimately become the absolute gold standard for dosing psychiatric medications in the future.
Just imagine a future where a smart pill practically adjusts its own dosage based on your precise morning hormone levels.
That would change everything. But until that kind of targeted medicine becomes a reality, keep asking questions, keep challenging the standard guidelines, and keep diving deep.